So now we'll switch across geographically to the Pacific, and we'll have two presentations about the PEARL project. And for those of you who don't know, PEARL stands for the Pathway to the Elimination of Antimicrobial Resistant and Latent Tuberculosis. There'll be a test at the end of the day for those who know what PEARL stands for. So Amanda and Mikaela, who's going first? Mikaela. So Mikaela Coleman, ex-executive officer for the CRE, received her PhD yesterday from the university and is now the project coordinator for PEARL.
Thank you. Okay, so green is forward. The button. Thank you, everyone. It's my privilege to present the PEARL project, which, as Warwick said, aims to pave a pathway to eliminate antibiotic resistant, drug sensitive TB and TB infection, as well as leprosy in the Pacific. So it's quite a big aim. And the study is based in Kiribati. I'll get to that in a little bit. But I wanted to thank Ben, who is the CI of this study. And as you can see, there are quite a few usual suspects on the list of CIs and AIs from the TBCRE. And that is because this is a true TBCRE collaboration that was born from this group of people. So I'm going to just thank a few people straight up. So thank you to Guy and Greg and Tuang, their team, for providing us with so much support to get started. And also to the Australian Respiratory Council. I'll hand over to Amanda in a moment to tell us the education aims of PEARL, but I'll be talking about the implementation of the intervention. And also a number of partners, just to call out Tauhid, who first suggested Kiribati as the study site. And I can't say anything without thanking the country partners. The collaboration with the National TB Program has been amazing. The Director of Public Health, Irasi Timian, has been incredibly supportive of the study, and she got it approved through Cabinet. And also the doctors of the NTP program, Doctors Alfred, Baranico and Tamea, who have volunteered to operate one of our mobile study clinics during the entire intervention. So many thanks to them, and also DFAT, who have provided funding and information for a mobile chest x-ray, the TBCRE, who have provided seed funding for the integration of biometrics into our REDCap database so that we can identify patients, and the University of Sydney, who also provided some additional equipment funding. And finally, this is funded by the MRFF. So thanks to them as well. Kiribati. Kiribati is far away. It is right in the center of the Pacific. It's responsible for that kink in the international dateline. And to steal a description from one of our DFAT colleagues, Dr. Rob Condon, it is the size of China and India put together. That's the territory size, but the land mass is the size of Canberra. So there are 110,000 people that live there by last count, and more than half of those people live on one island, the Tarawa Atoll. Tarawa, that top arm of the Tarawa Atoll, has very few inhabitants. It's that bottom arm, which is about 15 kilometers squared, that has 60,000 people living there. And Besso, which is right at the tip there, we can zoom in. Besso is the most populated place in the Pacific. I'll let you know that Kiribati has the lowest GDP per capita in Oceania. And as I've said, it's very densely populated. So this is where much of the TB in Kiribati is centered. And our study will be screening the entire population of South Tarawa. So that's 60,000 people in a community-wide screen. And we will find and treat TB, latent TB, and also leprosy. Why Kiribati? I've already hinted at it, but Kiribati has incredibly high rates of TB. In Tarawa, it exceeds 500 per 100,000. And as you can see by the distribution of age, most of those are in young people, indicating that there is ongoing transmission in the community. So it's a real challenge for Kiribati that we're hoping to work together to solve. Why are we including both TB disease and infection? Well, this is modeling that I want to thank James Trower for providing. This is from a similar intervention in the Marshall Islands by the US CDC. Dick Brostrom is one of our associate investigators. And if we look at EBI, which is B on this, you can see that when there is a community-wide intervention looking just for active disease and treating active disease, the effect is immediate. There is a reduction in the TB prevalence, but that this is not very durable. It's not a sustained effect because all of the latent TB remains in the community. But if we have a look at Maduro, which is A, you can see that when you combine community-wide screening for both disease and for infection, the effect is far more durable. So that's why we're combining both interactions, very similar to Act 5. And then why are we including leprosy? Good question. Warwick is on this grant, so that might explain a few things. But one, it was a request from the government itself. And if you have a look at the new case detection rate, it's incredibly high. Leprosy, Kiribati has the dubious honor of tying for first place as the most leprosy in the world per capita. The global elimination target is 10 per 100,000, and in Tarawa, it's sitting at about 200 per 100,000. And you can see from the new child cases, about a third of those cases are in children, indicating that there is a lot of ongoing transmission in the community. So we are very fortunate to be partnering with the Pacific Leprosy Foundation on a new grant that dovetails with Pearl that we have been invited to submit an application for to the Leprosy Research Initiative based out of the Netherlands. So watch this space, but we're collaborating with them. There's Professor Stephen Chambers from the University of Otago and the Pacific Leprosy Foundation CEO, Jill Tomlinson. And this is where most of our leprosy interaction will occur, and we'll be using the existing structures set up by this group as the surveillance mechanism, which is, yeah, just a wonderful collaboration. And if we have a look at a paper that was published by their group, you can see that when we combine, looking at that ugly yellow-brown line, when we combine household contact tracing with community-wide mass chemoprophylaxis for leprosy using single-dose rifampicin, we can get quite a durable reduction in leprosy across, modeled to be a very durable reduction. So we're hoping that our results will sit kind of in between that brown line and that blue line would be our hope. And so just to give our main study aims, we want to evaluate the effect of this community-wide active TB case-finding intervention plus treatment of TB infection upon TB incidence in Tarawa. We'll be measuring incidence before and after the intervention using the case notification rates from the NTP, and also to evaluate the effect of this intervention plus universal leprosy prophylaxis across Kiribati on the leprosy incidence. And we'll also be performing an ARTI for TB to look at transmission. So to talk you through the intervention and the steps, during the first face-to-face interaction with the community, we will be going door to door and enumerating every household and collecting detailed demographic information. And this will be populated into a detailed satellite map so that we can do geospatial mapping of disease and other things. So we'll be inviting every member of the household over 3 years of age to come to a mobile study clinic that should be no more than 500 meters away from their house. And if they have a case, a reported case of TB or leprosy in their household, then children under 3 will also be invited to be screened. We'll provide study information, and then the following week, the same enumerator will come and collect the household and bring them to the clinic, which is nearby. At the clinic, we'll collect informed consent. They'll complete a symptom screening questionnaire and a physical assessment looking for signs and leprosy suggestive changes. And then we'll place a TST and collect sputum from those who are able to expectorate sputum using GeneXpert with rifampicin detection, rifampicin resistance detection. And we'll perform a digital chest X-ray, which will be read using CAD for TB. And anything that is a positive, so over 50 on the CAD for TB reading, will be assessed by a panel of experts for confirmation. And then on the second study visit, which will be 24 to 96 hours later, that TST will be read. And the evaluation of all the study results will be given, so the expert and the X-ray results, after which a decision will be made. People who have no TB, no leprosy, and no infection will receive single-dose rifampicin as universal leprosy prophylaxis. Those who have latent infection will be provided with TPT. For adults, we'll be using 3-HP, and for children, 3-RH. And I should mention that those with latent infection, so those treatments for latent infection are also sufficient to protect against leprosy. So it will be leprosy universal prophylaxis for the population using either single-dose rifampicin or 3-HP. And those with TB disease or leprosy disease will be referred for treatment to the NTP. We'll document the outcomes and report. So just to let you know where we're up to in the study, all of our equipment and consumables and resources are either in country or on their way. The borders are still shut, but probably the most exciting thing is that Dr. Jeremy Hill, who's our study doctor, who will be living in Tarawa for the entirety of the study and implementing it, is in the audience with us, and he got out of hotel quarantine 2 days ago. So, yeah. And I'll pass on to Amanda to tell about the education components of PEARL.
And bring it forward, yeah. Okay. Good morning, everybody. My name's Amanda Christensen and I work for the Australian Respiratory Council, and we're very pleased to have been invited to be an implementation partner in the project. So Mikaela's described and given an overview of the first aim of the project, and I'll focus and concentrate on the second aim today, which is to optimise the care and treatment of TB through enhanced case healthcare worker training in the South Pacific. The work that ARC will be doing in this area builds on about a decade's worth of work we've been doing in the Northern Pacific. We've worked with the US Centers for Disease Control to look at education and training in the US affiliated Pacific Islands, and the work and expertise we bring to that project will be implemented through this activity. So capacity building for the workforce is needed to support national TB program activities to achieve optimal individual patient outcomes and programmatic outcomes, and to support TB elimination efforts. The package of activities that ARC will be delivering relate to training activities for the National TB Program and the PEARL study, development of a short course training activity, the development of a South Pacific TB nurses network, provision of mentoring and technical assistance, development of tools and resources, information education and communication materials to support professional and community education. Okay, so this project will be, the education component will be for both Kiribati and for the wider Pacific. So for Kiribati, we're going to develop and deliver in-country training workshop for healthcare workers within the National TB Program, and the focus of that will be on TB and leprosy to build programmatic skills and knowledgement. The education program was to be delivered this year, but as everybody says, COVID has an impact on that. So we will plan to deliver an in-country face-to-face training program sometime next year, as soon as borders open and travel permits. That program has been developed at the request of and in collaboration with the National TB Program in Kiribati, and it will cover the clinical skills, clinical and programmatic management of TB. There will be additional training for the PEARL project. You can understand undertaking such a large active case finding activity for up to 50,000 people is a large deal for a country to do. So we're going to undertake a detailed training activity, and Jeremy will be delivering that. Unfortunately, because we can't get in country, Jeremy will be delivering that with support from local staff. And that training will look at giving people skills in research, looking at their clinical skills. And Warwick mentioned before about sputum collection and quality of diagnostic samples. Will focus on that, tuberculin skin testing, and just equip the staff with the knowledge and skills to undertake the project. And with a real focus on data management and how that underpins the project. We're going to look at development and implementation of tools, not only for the project, but for the NTP, and looking at resources that assist with professional and community education. Okay, so the annual short course that we'll be developing is for the wider Pacific. So it's looking at building Pacific Island nursing capacity in the care and management of people with TB and drug-resistant TB. There are 6 target countries that we're going to be focusing on with this annual training activity: Fiji, Kiribati, Nauru, Solomon Islands, Tuvalu and Vanuatu. And those countries have been chosen because they consistently have an incidence rate of TB greater than 40 cases per 100,000. We're going to plan to do that in a spot. Fiji is the proposed site to do that as a central meeting point within the Pacific. It will be face-to-face training that supports and facilitates the learning framework for nurses. And we're going to run those courses over 3 years, again, when we can get into and when travel bubbles or travel permits. We're going to sponsor nurses from each of those countries to come to courses. The course will be also open to other nurses within the Pacific, so we won't be able to meet the cost of those nurses participating, but it will be a broader audience that we hope to reach as well. We're going to do clinical and public health management of TB, disease prevention, infection control, patient-centred care, and management of complex DRTV cases. The resources we develop will all be put online. There'll be a repository online so that the course participants, their colleagues in country, and then other people can access those resources. We think that's an important add-on from this project, that there is a repository of tools and resources and training materials that people can use to upskill in their own countries. We will also look to the work we've been doing in the Northern Pacific. We have detailed training resources. We have a range of IEC materials and tools. We have clinical competency standards and other resources that we're going to also make available. So we hope through creating a repository with all of these different materials and resources, we'll blend and combine these resources so that they will meet the training needs and needs of the NTPs within the Pacific. Okay, there's also the potential, and one of the good things from this project is that we have potential as we're gathering momentum and we identify ideas to collaborate with other groups and organisations. So there's the potential to collaborate with the International Council of Nurses to develop a train the trainer model of nursing education in the specialty area of TB. They currently have a training package for drug-resistant TB. With the work we've done, there is interest with working with that group to have another avenue for training and supporting, nursing education. And importantly, all of the activities that we're doing in the Pearl project are going to be integrated into a pipeline and a pathway for specialist education. And I'll talk about that a bit more on the next slide. So globally, nurses learn from on-the-job training. Nurses are a really important part of our TB program. Having a skilled workforce is very important if our programs are going to move towards TB elimination. So to address the gaps, we are working with I know Bernadette's here today, Bernadette Saunders, hi Bernadette, and Michelle Rumsey, who is the director of the WHO Collaborating Centre for Nursing and Midwifery and Health Development at UTS. We're looking at developing a pipeline and a pathway for nursing education. And what that means is it's taking the work we're doing in the NTP education program, those annual short courses, and trying to link them into the Masters of Nursing in Emergency Management through the School of Nursing in Fiji, so that the work we're doing all has some sustainability. It's adding capacity and value to educational activities that are currently happening. We've articulated that course outline. We're holding another meeting, I think, in a week's time, and we're looking at mapping that and trying to embed that into that course. And we also recognise that this pipeline, to address the gap in nursing education over the last 5 years, ARC has been undertaking a project with the support of the National Australian TB program, and the jurisdictions have actually supported financially and through capacity to develop a Master of Nursing in TB Management that was implemented last year in 2020. There are 3 specialist units that relate to TB. My colleague Kerry Shaw from ARC led the writing of that work, and our ARC Nurse Consultants Group with a national reference group have developed and implemented that course with Western Sydney. There is interest from Western Sydney to take the work that we're doing in the Pacific and create the Master of Nursing at one end of a pipeline, and all of the other specialist courses fitting into that, so that people can do a range of education from individual standalone units of study, certification of units, grad dips and a master's. And this is the first course that exists internationally of this type, and we're looking very much to embed what we're doing through Pearl and extensions beyond that into that pipeline. But there's a lot of work ahead for Bernadette and Michelle and I, so we continue to work on that. No problem. Thumbs up from Bernadette at the back there. Okay, so one of the other things is that we're aiming to develop a network for National TB Program staff that builds on the relationships and communications between the National TB programs to enhance patient-centred management and the management of complex cases. So we have for the past decade had a Northern Pacific Nurses Network where we meet monthly, we do case discussions, we have educational topics, we talk about surveillance and epi, and this network has proven to be really successful. Last week we had a meeting and we had 22 different people online from about 8 different countries. It was a network created for the nurses and the community health outreach workers, and we've got the doctors creeping in the background, and we're gathering momentum, and we have lab colleagues joining us as well. So we're looking to replicate the success of that into the South Pacific. The group will identify their own training needs and priorities. We facilitate and coordinate that, but it's very much a network that's owned by, driven by, and contributed to from the group. We implemented that in the Northern Pacific because we thought having annual training activities or intermittent contact with people wasn't enough for sustainability. So this course reinforces the work and links to, again, it's part of that pipeline and pathway for education. Importantly, many of our colleagues within the Pacific work in very isolated settings. So it's really important that they get to share their collective expertise. The solutions often come from within the group, and that's one of the features that we find Pacific solutions to issues and challenges that arise. Okay, another feature of our work with the Pearl project is the development of a South Pacific TB register, DRTV Register. So it's going to be developed as a REDCap database, as a surveillance tool to collect key clinical and laboratory data. It's going to have, and I'm saying it's going to because the work hasn't started yet, but the aims are that it will have a system to inform WHO of new cases, so an alert system. It will link the Pacific Island clinicians to expert advice, and that expert advice is currently provided by our colleague Rick Stapleton from South Australia and Simone Barry. It will link to the WHO second line drug stockpile to assist the islands to access drugs to treat DRTB. It saves small island countries having to have a repository of drugs that may not get used or are difficult to procure. So part of that is looking at how to procure drugs and getting support, advice and mentoring to do that. And then there's the added advantage of then being able to develop educational and mentoring activities to support optimal patient outcomes and outbreak prevention. So that piece of work will start from later this year. And again, there are opportunities to expand that in a whole range of directions beyond the Pearl project, which is an important feature. Okay, so in closing, I'd like to acknowledge, as Mikaela had said importantly at the beginning, our colleagues from the Kiribati Ministry of Health and Medical Services, our ARC nurse consultant group, Pam Banner, myself, Chris Lowbridge, who's with us today, and Kerry Shaw, Bernadette Saunders, one of the CIs from UTS, who's helping us shape the educational component, Michelle Rumsey, the Director of the WHO Collaborating Centre for Nursing and Midwifery, Project Lead, Ben Murray, and Jeremy Hill and Mikaela for your input and contribution to the educational activities. Thank you.
Do we have any questions or comments? Right up the back. Terrific. Can we hear Chris online, or do we have to read it from the chat? Right.
Oh, hello, Angela Izzo. Is there a BCG vaccination program in Kiribati?
Yeah.
And how will that affect your PPD skin tests, et cetera, and do you think that would, the question is, why hasn't that had a significant effect on the increased number of incidents of latent TB in that population?
Yeah, I can probably just say the data that we have is that BCG uptake is relatively high in Tarawa. We know that BCG hasn't had the desired impact on TB incidence globally. It probably does offer some protection for young children. So we're not sure what the TB or leprosy rates would have been in the absence of BCG, probably a lot higher. But that's part of the reason why we focus on children older than 3, because the BCG false positivity rate following at birth vaccination is greatest in the first 2 years of life. So we would essentially regard a positive skin test in a child older than 3 as likely TB infection, even though there may be some BCG effect, but the effect is mainly concentrated in the first 2 years of life. If a child has had household contact with TB, we will regard a positive test as positive, whether they had BCG at birth or not. So that's why those kids under 3 who's had household contact will be included and screened and provided preventive therapy, knowing that there may be some BCG effect, but the risk is just too high to ignore them.
Okay. Other comments were?
I think just to make a general comment, having been to Kiribati a few times and seen the difficulties they've got, but for the last 15 years, their TB rate's been relatively static at about that 400 per 100,000 rate. So there's been a lot of pressure on the system. Their drug-resistant TB rates have remained fairly low for a long period of time, but there's just a sense of an emergence of drug-resistant TB cases and that the system's beginning to crack a little bit under pressure. So there's a whole lot of issues in the Pacific that create major challenges, and this will be a very challenging project, but I think it's very timely because at a point where there may be a shift in the adverse nature of TB cases occurring, it becomes timely. I think to answer the BCG question, there must be high rates of transmission of community transmission going on. There's the pressure from the rising sea level, so people coming in from the outer islands into Tarawa. So the housing density, or the density of living, I think is about 10,000 per square kilometre in Tarawa. So it's an ideal population, I think, to have a crack at in the way that the project proposes. So that just general comments to make about the general situation there.
Right. We'll have a list later of people who would like to come and participate in the program and visit Jeremy and participate in the screening teams after appropriate training. Yes. Yeah. Chris, do you have a question from Chris Coulter, I think?
So Chris asks, what is the plan for leprosy lab diagnosis and monitoring? For instance, slit skin smears, bacterial and morphological index, molecular diagnosis, molecular drug susceptibility testing. How will lab capacity be strengthened and quality managed?
Right. So Chris is asking a question around leprosy. So Pearl has become, the L in Pearl also stands for leprosy. And this was a hope until we really made contact with the Pacific Leprosy Foundation, who've been working since 1954 in leprosy control in the Pacific. And about 10 years ago, they, in collaboration with the Kiribati government, have a memorandum of understanding to support the leprosy program, which was not coping with the number of patients and which had been run down following the leprosy elimination program of WHO, which did everything but eliminate leprosy. And they have supported and actually fund a manager for the leprosy program. They've developed robust systems. They've trained a doctor from Kiribati and also provide consultation with an expert from the Philippines 4 times a year. They don't use slit skin smear, but they have used biopsy to provide, which turns out that it is easier to provide punch biopsy, which is actually then read in Christchurch, and they have actually set up the PCRs for both for leprosy detection, but also both rifampicin and dapsone resistance, and as yet have not detected rifampicin resistance, but have detected a low rate of dapsone resistance. So this provides an ideal combination because of their commitment, and so through our joint application, we will hope to be able to expand that to the whole community. So there is a functioning program with which we can operate. They've also been of great assistance in some other practical aspects of getting things done in Kiribati, which is a good thing. Yes, Steve, and then we'll move on.
Yeah, I'd just like to, just a specific issue that's pragmatic is in the detection of disease and infection is the stage at which you test for infection. If I got it right in Act 5, it's skin test positive first, and then you go on to treat and detect disease after that. So you may miss skin test negative people with disease. Whereas here you're doing it all at the same time. And whereas in PNG we're thinking that we would do the active case finding and rule out TB first for disease and then skin test. But but it is important because it's all these, how many visits you can do and etc. So it's a challenging area, I think.
I think actually, I mean, as you know, Steve, there's been a lot of discussion about this. And I think actually these 3 studies, including the one in PNG, will actually provide, different views of the problem and actually provide some evidence base for how these interact. And I know the CDC program in the Marshall Islands that Jeremy was involved in also had a slightly different approach. And so I think it's very helpful that actually through the CRE that we've got the collaboration of these different programs. And I think we'll need to both evaluate and then also use this data to advocate for an extension of this. Even the household contact screening, which is coming up at 2% of patients, again in Indonesia today, similarly to what Greg found, that's not being widely utilised. Okay, so in our journey around the Pacific, we can now move to journey around Asia. First, we're going to Vietnam, and then we're going to PNG. So Greg we're going to move on now and talk about new models of care to reduce TB mortality and to improve outcomes. So Greg, and then Angela Kelly will present us.